Good evening, everyone. We are going to start the webinar shortly in the next 5 minutes. Good evening, everyone. We'll start the webinar shortly. My name is Dr. Kemunto. I'm the moderator for the session today. The topic of discussion is research proposal development. We've had this series where we are talking about research, and today the topic being proposal development. Will go a long way in ensuring our young researchers in the academy get the necessary tools to develop their proposals. This program is supported by HIVOS in collaboration with the SRHR Fund and hosted in the Medical Learning Hub, together with now KMA. The speaker for today will be Professor Ruth Ndwati, who's a professor of pediatrics at the University of Nairobi School of Medicine in the pediatric department. Prof. Ndwati is a renowned researcher who has done a lot of work in child health, particularly HIV and mother-to-child transmission. And last week we had her for the session on ethics, which she covered quite extensively. I'm sure today she'll also do the same. To add, Prof. Nduati recently received an award from the National Research Fund for the award on National Outstanding Research Award. She received a lifetime achievement for her work and commitment towards research. So congratulations, Prof. And you can take over the floor. Just housekeeping, if you have any questions, kindly put them in the Q&A box, and you can use the chat as you may to interact with Prof. Karibu, Prof. The floor is yours. Thank you.
Good evening. Thank you very much, Dr. Linda. Thank you for the kind introduction. This evening, we're going to talk about proposal writing. And I want to assure you that this is Kiondo, you know. The idea is actually to go through each of these sections that go to a proposal, to actually go through it week by week or lecture by lecture as you prepare your own proposal. But this will give you a feel of what a proposal looks like, okay? Now, my objective is at the end of this lecture, you should be able to list components of a research proposal, list some of the basic criteria in selecting the related research questions, methods for developing the research question. This actually is usually the most important thing in developing a proposal. And then also have some ideas about potential sources for research questions. We'll spend quite a bit of time looking at study designs, and I'll give you examples so that you see how what was the research question, how they ended up with the study design that they did, and we'll talk even a little bit out of the advantages and disadvantages of different clinical research methods. Again, as I said last, some of these slides are from this team that taught on micro research a while back. Others are slides I've used over the years in teaching this subject, and also, you know, just new stuff that I've tried to put together for this particular lecture. Now, if you're scribbling or you have your phone, you can take a photo, and really these are the components of a proposal. You need a brief background, a review of literature, a study justification or study utility. Usually this gives us summary points on what the problem is and why the intended research is useful. Then you have your research questions, your specific study objectives. You go into the study design, the study setting. You talk about your study population, what your case definitions are, your sample size and sampling. And to go back a little on study population and case definitions, that's where you also talk about inclusion and exclusion criteria. Then you talk about sample size and sampling. How will you identify the participants? And this is dictated too by the study design you adopt. You go into study procedures, data management, data analysis, ethical issues. Now, we talked a lot about ethical issues last week. We will not be able to deal with all these bits in detail, and you can see why I said that this is really just a flavor of how a proposal is written. But we'll touch on them, and you'll see how each of these things applies. This study is done. 14 components to your research proposal. Now, the study title, it's usually the last slide to be done. This is after you have defined the research questions, you have you are clear what your study design is, what the study population, who the study population is, the outcome of interest, and the study sites. Because all these things need to be reflected in your title. And then for you, as you are doing this, you'll be the key investigator if it's your proposal, or if you're a team, the team leader, and then everybody would be listed. Then who your supervisors will be, and here I was just, and then usually the funders like to be acknowledged. So if you have a grant that is supporting the research work, it's important to quote it. By doing this, you see, when you give credit, to people for what they're doing, it encourages them to sustain, the support and the funding. Yeah. Let's start off by just talking about what are the basic criteria for a research question. Can we use? We should use a chatbot also to communicate. And I would like to ask you to maybe post a few answers to this to the chatbot and see whether we can share a little bit. Yeah. Please just do send a chatbot. Let me see whether we have any idea of what the basic criteria for a research question is. Giving you a half a minute to send something there. I don't see anything today. I think you're still there. Okay, we will continue and thinking. The basic criteria of a research question is that it must be possible to answer it. I see this one post there in the chat. Basic criteria: who, what, when, where, how. Yeah, those are part of it. Yes, thank you, Valentine. You learned how to frame using picots. Is it feasible? Right. I see you are listening when you are having these sessions, and about final criteria. Yeah. Okay. So it must be possible to answer. It must be specific. It needs to be of interest, relevant to you and to others. And I found this statement by some of the researchers there that a legitimate scientific study is not to prove that something is true, but rather to find out whether it is true. So we don't start off with a preconceived idea that this must be the answer. We are really asking whether this will be the answer. There are many questions out there, and you phrase the broad question, but the idea is to narrow down to what you can answer. Now, as you do answer this, the scientific method you follow must allow for the exercise of imaginative insight. It's important you have this, but it also places checks on the constrained use of imagination. You must be able to have a mechanism to distinguish claims that can be substantiated from claims that cannot be substantiated. And we'll come back to this. What is the criteria of saying that something is actually having a causal relationship? And it's not just putting out, something out of the hat. Ideally, you should start off with broad questions and then narrow down and focus in operationalizing. You observe, you analyze data, you reach conclusions, and generate back the questions. This is sort of like the flow of research. This is usually the framework presented for example, social research, but it's also a framework that works for other types of research, where you will start off with a broad question and then focus down and into several secondary questions, several specific aims. Sometimes you may be able to look at several questions at the same time in one study, but many times I think you need to go through a series of studies to actually get the answer that you first thought about as a broad question. We must be ambitious in doing our studies, but we must also be realistic in that we focus on a question that you can answer. We can't answer all the world's questions in one study or even in one lifetime. You refer to this Picot system, and which may be useful when you're taking on an intervention. So being able to say who's your population or patients, what is the intervention, what is the comparison, what is the outcome. It helps you to think through, and this is useful particularly for randomized trial where you are giving you're doing an intervention, or in the pseudo-randomized studies. Now, where do the questions come from? I see a comment about the audio. Can you hear me clearly? Can I have an answer, please? Can you hear me clearly? Dr. Linda, can you hear me? Yes, I see. I've gotten the answer. Thank you very much. So where do research questions come from? Let's post a few ideas on the chat box. Where do you identify questions from? So, and you can even unmute yourself and say something. You say from personal experience. Do you want to extrapolate that a little bit more? Tell us one example of a question you've asked and done, or you'd like to ask. I see gaps in knowledge. From looking at a clinical encounter, by questions by direct interaction with our environment, as in the case of discovery science, and from previous researches. Yes, so we find research questions within our own environment, the patients we interact with, the observations we make, when there's variance with what we expect and what we actually find. That is creates a fertile ground for research questions. And I want to encourage you that even as you practice as medical doctors and as dentists, pharmacists, keep an open mind of asking the question, when you meet a scenario, is this expected? If it's not expected, why is it different? What could have gone wrong, or what is new? And this becomes the basis of developing a research question. And I agree, all those things you've listed there, including the clinical audit, are sources of research questions. And this is what this slide actually says, our workplace discussion with colleagues, those debates we have from reading the literature. So you need to keep reading the journal articles, the East African Medical Journal and others, attending scientific meetings or webinars. Again, that's an environment where you might get new questions. The WHO guidelines around any of the topics. Usually at the back of that guideline, there's a list of the unanswered questions. So that's also a good source of questions when one is looking around for ideas to do research for themselves. And as I've said, developing a culture of inquiry, being able, the culture of asking why, how best to do something, and when. In writing your proposal, these discussions and observations inform the background and study justification. So the introduction may talk about the current status of the condition you want to investigate, and it may go into even the anecdotal observations that for example, the guidelines are A, but you're operating in a situation that is B. Then your literature review goes into now where you have gone to read the literature and see what others have found, what the guidelines are, and why. And then with this information, you're able to then go and justify actually doing the study. Usually we'll do about 2 slides for the background when you're doing a presentation of your proposal, because I guess that's where we are heading to, a presentation that can tell what you want to do. It usually ends up being 2 slides. You start from the global and come down to the local situation. So if you're thinking of asking a question around adolescent reproductive health, teen pregnancy, you might want to say, so what is a global problem? And why is it important? And then in our Kenyan context, what does it look like? If you're doing a study in a county, a particular county, how does your country compare to other counties? And then also, what have others found out? Aim to focus on recent other publications in the recent 10 years, unless the subject is so infrequently investigated. So you can go back to your 20-year or 30-year-old paper, because that might be the most current publication on a specific area. Today we have PubMed, and even just Google. It allows you to be able to access a lot of information, and you use keywords, to do your PubMed search or your Google search. And I hope you've had a session on how to do this. And this will lead you to articles related to subjects that you want to study. Usually you start off by scanning the abstract. And then once you've identified the papers that look like they are really in the area of where you want to do your research, please read the whole paper, okay? Read the whole paper, not once, twice, 3 times. Understand what that team did and how different is it from what you're going to do. Let's get to this question of what kind of a question you're asking and what methods could you use to answer that question. When you read other people's work, you have there in front of you the question they asked and the research method, the methodology they used, and the results that they found. And I'll give you some examples later how, depending on the method, the study design you use, you can have very different results about the same health problem. So you then in your proposal, your statement of the research question and study objectives is usually 1 slide. So you have an overarching statement of what's the broad research question, And then the specific aims, broken down. And these need to be smart. They need to be something you can measure, and can be, somebody else coming to do the study can be able to replicate exactly what you've done. Now, there are different categories of research questions. For example, there are questions that look at the natural cause of an illness, the prognosis or outcomes of a health condition. This is looking at, so there are studies looking at, say, disease progression. There are studies around cost effectiveness or clinical decision making analysis. Are we choosing the most cost effective approach? So you quantify, you be having two choices and you quantify the cost. It may be clinical decisions that you're making, and you're asking yourself, are they giving you better outcomes in terms of survival of the patient or time to recovery? And then the other category are studies where you're looking at the feasibility of a new practice or emerging trend. The tendency for this category 3 of questions is to use randomized single trial design or pseudo-randomized design to answer this type of question. Now, putting in time to brainstorm with your colleagues. So building a team around you who you discuss is very useful. It really helps you to distill the research question that, and the research objectives that you want to address. And don't feel afraid to be criticized. It's not you who's being criticized, it's actually the question and the topic that is being discussed. And as you identify the problem, for example, head injuries, how can they be decreased? Then you want to develop a hypothesis and then the type of research you actually want to do. Many years ago, there was a situation like this. The big hospital, Harborview Medical Center, which is a big public hospital in city of Seattle, they asked this question, and the problem for them was that there were many children, adolescents, being admitted with head injuries. So they did a descriptive study where they were able to identify that most of them had been injured when they were cycling on their bicycle, either hit by a motor vehicle or falling off their bike, any one of those. They hypothesized that maybe if we had a law or it required people to wear a helmet, bicycle helmet, so that it protects your head, we could reduce the head injuries. And this is what they did. So they then went and they did a randomized trial. And lo and behold, the results of their study informs policy to this day that we all need to have our children, our motorbikes, our bicyclists to be wearing bicycle helmets. And when they wear these helmets, even if they're involved in a road traffic accident or they have or whatever, they have significantly reduced risk of having a head injury. So that example shows how people brainstormed based on the clinical cases they were observing, and then went through the process of doing the study. We can't emphasize enough looking at literature, talking to your colleagues. Don't do that story where you think, I'm writing a proposal, this is my intellectual property, I'm going to hide it, I don't want to discuss with my friend. That is not the way to succeed in research. Being able to be open and have that debate actually strengthens and refines the question you're asking. And then, of course, you need to be observant. And the observations will also help refine the question. So spending time in a clinical setting, for us who are in this health sector, it's not a waste of time. It's an opportunity to develop new ideas, to hone new skills, and be able to go on to do stuff that, particularly research, that can inform care, can inform practice, and can be the basis of our career. Now, once you've done this discussion and all that, you then, of course, have your study justification, and it is usually one slide. We don't like too much information there. Albert Einstein said, if I had an hour to solve a problem and my life depended on the solution, I would spend the first 55 minutes determining the proper question to ask. For once I know the proper question, I could solve the problem in less than 5 minutes. This statement is so true even today for us. We've been writing proposals over the years, and there's the format of our proposal writing is that you have what we call a specific aims page. Usually it's 1 page, and where you give a little bit of a background and justification, and then you state your overall objectives, and then your specific objectives, and very briefly, in like 2 sentences for each of the objectives, you describe how you're going to achieve that objective. And we spend a lot of time back and forth discussing that 1 page. And then when and it can be even a couple of months, actually, just back and forth. Once we are clear what is now our objectives are, and within that, we already, in our objectives, we already formulating the strategy that we want to evaluate. It then takes a very short time, and maybe a month after that, to actually complete all the other sections of the proposal that we're pulling together. So this first stage of thinking through, thrashing through back and forth, having clarity of what the question is very important, and you need to spend time on it. You need to, discuss with your colleagues. And I would even encourage you that this is the first time you're all doing research. It might actually be useful if you worked as teams, as opposed to being me and my proposal under my armpit, so to say. That you have to work as teams, and the ideal teams, of course, are ones where you also are they're interdisciplinary, and debate through these questions. We hope you'll get an opportunity to present to each other, get critiqued, develop it further. And that way you will get a good proposal. You have a good question that can be investigated. Now let's talk about methods. This is the next section of your research proposal, the method section. And it says, it tells a person what you did or what you plan to do, and they should be able to replicate that if they came back and get similar results if they're doing the study in the same population at the same time. Remember that as time goes by, populations change. So you may use the same study design, the same research questions, but you actually find that things have changed because over time, new things have happened within that population. About the study design and the study site. In presenting this information, usually it's just 1 slide. I will now spend quite a bit of time talking about the study design, because this is really then the other crux of the matter in terms of writing your proposal, and it actually then determines how you select your study populations and how you collect your data, etc. Now, the ultimate goal of any of these epidemiological studies, we use epidemiological methods to investigate these questions, okay? And the ultimate goal of any epidemiological study is to compare an incidence of disease in an exposed population to the incidence in that population if it did not have, if it had not been exposed. This is clear, really the basic thing, And then to obtain a measure of association between an exposure and an outcome. And there are different things with relative risk, attributable risk, etc. Odds ratios, the works. And the measures we use, the measures of association we use depends on the study design, okay? So broadly speaking, you have an environmental exposure or a host characteristic, and an association is observed of a disease or other health problem. So the host has a characteristic that they see that is associated with a disease or other health outcome. And in doing this research, the first question is there an association observed? Is this disease occurring more in those who are exposed compared to those who are not exposed? And then the second question one asks is this observation this observed association, is it causal? This is a very important concept. Keep coming back to it until it becomes second instinct to think of it this way. Yeah? The first is there an association? And then two, is it a causal association? The kind of studies we subject to this kind of thing are, for example, evaluation of a test, its accuracy and usefulness. Just think of a malaria slide. We want to check it and a rapid diagnostic test. Usually the test, the gold standard would be the malaria slide. So when you do the rapid diagnostic test, is it accurate? Okay. And how useful is it? These studies have been done, of course. That's why we have rapid diagnostic tests in the market. It may be evaluation of a therapy. So this is a classic, usually the classic design is a randomized trial of a product to see whether it is effective. So, and also, or even whether it achieves prophylaxis. For example, tetracycline eye ointment. There was the all-important randomized trial. Actually, it was done in Pumwani maternity, which showed that administering tetracycline eye ointment soon after birth of newborns prevents ophthalmia neonatorum. Usually, the ophthalmia neonatorum was due to it's an important cause of blindness in children. So by just doing that randomized trial, there was a subsequent one that was done, I believe, in Nigeria or Ghana there. And they then looked the same randomization, but looked at those who got the prophylaxis within an hour of being born, but it's those who got prophylaxis up to 12 hours later. And they showed that you really need to get there within the first hour or immediately after delivery to be effective. And the design of such would be in this category of B. You're comparing one versus the other. Then there's the C, which is the examining the cause and clinical conditions. These tend to be, sometimes you can use the randomized clinical trials, but they tend to be observational studies. And I've listed the different ones, and I'll show you a slide on that. Now, the selection of the study design is based on what is the hypothesis that is being tested. Two, it is what resources do you have available? And three, what is the current state of knowledge? And it's important you should select the most appropriate design. You need to also consider the available resources there. When you consider the available resources, there are things like, do you have a study population? Do you have access to a study population? Do you have money to do the study? Is there the technology to do what you plan to do? More than 30 years ago, we wanted to look at the question of mother-child transmission of HIV. And at that time, the PCR test was just being developed. You know that the way we collect paper, infant blood on a paper filter, this was just being developed. So a few years before that, use of filter paper blood samples would not have been feasible, and would have had to draw blood and put in bucket in tubes and separate PBMCs and store them and serum separately for us to be able to do the HIV testing on those infants. But now when the technology was developed, it not only became beneficial to us as we're doing our research study, it has become the standard of care now, so that newborns of HIV-infected women or infants of infected women, we collect samples on those filter papers. So the resources, the story of the resources is important. The significance of the problem is important. It's like we now have this story of imports. But now it's emerging that imports was first described in 1959. So it's been around for a long time. It's been around for more than 60 years. But it wasn't something that we were very much aware of, or even any government would start putting money aside for prevention of imports. But now the circumstances have changed. We have seen an increase in the number of cases. We have seen increased transmission. We've seen a variant that has bad outcomes. So it's now a significant problem, and so needs to be investigated, and that would form part of what we call the justification of carrying out the study. If you had an observation where one remote, very remote observation, it may be very hard to justify a study. It may be that the population is not at risk. Say, for example, setting out to do a study on sickle cell disease in the middle of central Kenya. It's a non-malaria area. Very few, very, very, very few people have the condition. So even if you wanted to do this, to study it, it would take a very long time to accrue your study population. Yeah. Now, you need, to select your study design, you need to decide whether you're doing an observational study or an intervention study. The observational studies are those which they are non-experimental. You, as the investigator, you observe the individual or communities without manipulating or the intervention or intervening. So you're an observer. While in the intervention trial, you, as the investigator, you intervene and you look at the effect of that intervention on an outcome, a defined outcome. This slide puts the study designs very simply. These are the design of coded studies. You have non-experimental and experimental studies. In the non-experimental, you have descriptive and analytical studies. Descriptive is a series. This is seen as the simplest form of organized research, but it's very important. The reports of, I think, one case of imports in our border is what put our government on alert that we have a problem. I believe now we have 2 cases. So, but those 2 cases are important. The AIDS epidemic was first flagged off by case reports among PCP pneumonia among gay men in North America. Then we have the analytical non-experimental studies. So there's a cross-sectional design, which we use a whole lot, and I'll show you some of the ways they use it. the cohort study, the case control, and in the cohort study, there's also the ecological or population-based studies. In the experimental studies, we have the randomized randomized clinical trials, and we have also non-randomized, what we call quasi-experimental field trial. This could even be a study where you are a before and after. So somebody is a control for themselves. These are more the same study, but now also highlights that these designs can be applied to individuals, but they can also be applied to populations. So, for example, the observational study, the health service we do, a cross-sectional service, and they're applied to whole populations. And when the data comes back, it's data about a population, okay? Or they can be applied to the individual, in which case we have information of the individual as a person. And they can be analytical, so like a cross-sectional or prevalence study. It can be a case control study, or it can be a cohort study. A cohort study being a study where we follow up patients or individuals. While case control, you identify people on the basis of having already having the disease or not having the disease. And again, I've explained the randomized trials. It can be randomizing individuals. It can also be randomizing communities. And like cluster randomized trials, if you go and Google them, they become very popular. When you go and put in an intervention into a healthcare system, and you can do a cluster randomized trial, or you can do a quasi-experimental where you collect data before and after the intervention. So a facility or a community is compared to itself. This is important because sometimes a community is a complex entity, and there may be differences within there between one community and the next, which could explain the differences you get in your results just by purely that they're two different communities. But when you compare a community before and after an intervention, you control for these differences. And so you have a more powerful data in terms of determining whether the intervention you are talking about actually is working or not, whether it's behaving the way it behaved in, for example, in strict randomized clinical trials. Now that you're in the community, is it performing as well? So again, thinking through clearly, what is my research question? What study design will best serve that thing? So the case series have some advantages. Usually it can be you've just observed a single case, and you are then or a group of patients with the same problem, and you can already formulate a hypothesis. The disadvantage is that, of course, it's based on the experience of one or a few people. What is identified as risk factors may be purely coincidental. They are completely unrelated. Or and of course, there's a lack of an appropriate control group, and they're not able to generalize. Now, let me just pause a little bit and ask, are you aware of any conditions where one case is a basis of actually going out there to do an investigation? Any diseases you know? And you can post to the chat box. Yes, this is good. Mpox. What else? Ebola. Anything else? The other things like polio, isn't it? Flaccid paralysis. There's a compulsory requirement to report and for it to be investigated. Others require a bit of a cluster, things like measles, a cluster of measles, even a cluster of things like whooping cough, will cause an investigation to be carried out. Even other the case reports are important. They're very important. They have often been the basis of identifying new and very important health issues. So it's not just this import or the fact that this is how we identify the issues, some of the issues about HIV. It continues to be a very useful tool. For example, it may be the first pointer to an environmental contamination, maybe a cluster of cancer, a specific type of cancer in a population. Maybe the first thing to tell you there's a problem. We have also ecological studies, and this looks at populations and not individuals, and you look at association between behaviors and outcomes in populations. So, for example, comparing smoking rates and lung cancer deaths in different regions of the country. This kind of approach, of course, is prone to bias, and the relationship between the exposure and the outcome of interest may actually not be causal. However, they are quick and relatively inexpensive, and they can be used to generate a hypothesis so that people can go in and do a bit more detailed research. The difference from cohort studies is that there's no information on the individual in populations. And the cohort study, usually the data pair exposure and health known for each individual is available. But here you don't have you only have the information of the whole population, but not the individual. Now, let's talk a little bit about cross-sectional survey. This is one method I think will be one of the commonest methods you will use for your studies, and even you may use this for your whatever for the proposals you're going to be writing, and you can do a survey on very many different things. The characteristic of the prevalence of the survey is that the exposure and the disease status are assessed at the same time. You can do it over a specific window period, for example, as a community survey, or fixed in a course of events, e.g., baseline pre-employment assessment. It will provide you with frequency and characteristics of a disease by providing a snapshot. It's like a photograph of the health experience of the population. This study design is very useful and used for many things. Some of the examples of cross-sectional comparative studies are, for example, the study by Lettner and et al., which described in 1977 the occupational determinants of chronic disabling pulmonary disease in rubber workers. They did a survey of 2,856 production workers at a rubber tire manufacturing plant to determine the prevalence of obstructive airway disease. They looked at workers in different sections of the manufacturing process and compared them. And after controlling for age and smoking, milling and calendaring and tube inspection were associated with higher prevalence of chronic obstructive airway disease. These are procedures where you're handling heated rubber. And this is the study that generated the hypothesis for studies that demonstrated that heated rubber caused chronic obstructive airway disease. So the cross-sectional study became the basis of generated the evidence and the justification for doing now the subsequent cohort studies. This is another example of a study on coronary heart disease among white male farmers aged 40 to 74 years. This is it's published study that was published back in 1965. And you can see this is before people really truly appreciated the importance of being physically active. So you can see the numbers they examined, the number with coronary heart disease, and then you have the prevalence. So 157.2 per thousand in those who are not physically active, compared to 33.3 per thousand in those who are physically active. If you had not stratified by the people's activities, you'd have had an overall score, I think, of 95.0 per thousand. But really, when you stratify, you can see that the issue are the problem is lack of physical activity. We then usually present the data in a way that age-adjusted prevalence rate. So, and you go back and look up your EPI books to see how you do those age-adjusted figures, but you can see they are presented there. Message very clear. So this was useful for this exposure to lack of exercise. I will show you other examples where the cross-sectional survey wasn't where the whole story is. Now, here is an example of this cross-sectional surveys. They are very important in public health, and we look at them periodically. So one is the first one here is looking at skilled delivery assistance, and by county, and we can see the rate, what proportion of women are attending skilled birth delivery, skilled attendance at the point of birth delivery. And if it's very low, then we know we need to go out and find out what the problem is and improve our practice. So it says 9 out of 10 women at a skilled delivery. But if you look carefully at the figures, some regions have got as low as 57%, 55%. So the stratifying by the different, doing your cross-sectional survey and then stratifying by the different populations allows you to have granularity about your data, about the incidence, the prevalence of a condition. This other one was also, this was selected that we're using for a presentation, but it's on children who are fully immunized. Now, the fact that the 9 out of 10 women skilled delivery showed up in a big hospital. But then 1 in 2 children are fully vaccinated nationally. So it means that these facilities, the women are coming with their babies, but these facilities are not coping in terms of providing service. This is a cross-sectional survey. One would then want to go and find out really what is happening. Maybe the women don't show up after they've had a baby, they don't show up. So you have the services there, the health workers are there, but the clients are not coming. And I found this a fascinating piece of data. It's from the 2022 Kenya Demographic Health Survey. I think probably the program that is most studied and use of this cross-sectional survey data is HIV. And here is a slide that just shows at this one point in time, I think this was the 2022 data, how we were doing in terms of HIV testing and viral suppression, and by different population, groups. Again, the use of cross-sectional survey data. In this case, it's looking at the data of at one point, there was the demographic health survey data. There's also the data at the point baseline, the baseline data when a woman turns up for antenatal care. Also what proportion of women showing up for antenatal services are tested. And if they are tested and are HIV positive, are they on ART, Then if they're on ART, are they virally suppressed? So you can look at that as a cross-sectional thing in the fertility. You can present the data like there. So this is how, and it looks good. I think it looks good. Or you can look at what is the deficit. That is to have the 95-95 target. So what is the deficit? How many points or how many percent points are we away from achieving that goal? So the cross-sectional survey data does lend itself to this kind of analysis. You then can do serial cross-sectional survey to show trends over time. And this is a standard approach to surveillance or monitoring progress. And this figure here is the cross-sectional surveillance data for Kenya on how we are doing in terms of prevention of new HIV infections among children. On antiretroviral coverage among pregnant women in Kenya. And you can see we are stagnating in terms of our women accessing their ARVs. And so we can see how the infection among children is starting to accumulate. That's been picking up. Then we can see also how we are doing in terms of coverage for among pregnant women. So again, serial cross-sectional service, and this data forms the basis of planning. If you go and get demographic survey data, you will see at the back the layout, the methods of at the beginning they lay out the methods. They describe all these sections of the methods, and then at the back they have the survey tool that they used, which you should be looking at because they can help you in being able to define your variables of interest, whether it's age, whether it's gender, whether it is wealth. How do you measure wealth? The Kenya Demographics Health Survey, the way they define that is useful. It means that you can compare your data to existing databases. They have used it for so long. It is well tested. So we talk about being creative and innovative, but sometimes you need to be standard so that you can have data that you can compare to others. Now, the limitation of cross-sectional studies is that, of course, causal relationships cannot be determined. You're measuring the egg and the chicken at the same time, so to say. And then in a cross-sectional study, it will always reflect the determinants of survival as well as the etiology. In very, very special circumstances, the cross-sectional data can be considered to be analytical if the exposure variable is unalterable. So, for example, if the exposure is having color blue eyes, or your blue or your blood group, these are things that you can't change about yourself, then the measures of disease association we find with that are they can be considered analytical in that context. The other useful study design is a cohort study. It's an observational analytical study. So it's a next level up in terms of the level of evidence. the cases and controls are defined on a basis of exposure to suspected risk factor for disease. So cases are those who have been exposed, and the controls are those who did not get exposed. So everybody starts off without exposure, and then the cases get exposed, and the controls are not. And at the time of exposure, all potential subjects must be free of the disease under investigation. And the eligible participants then are followed over time to assess outcome. Here's a picture of what a cohort study is. At the beginning here, you have your study population that's free of disease. One group then is exposed, the other is not exposed, and then the disease, the outcome. It's important that the researcher is not determining what exposure an individual have. That is, unlike a randomized trial where you as the investigator actually assign somebody to a particular intervention. Now, as I've said this, the first sentence I've said, it's we are observing and we don't control whether the patient or the participant is exposed or not. And the proportions of in your study of people who are exposed and those who are not exposed do not need to reflect the frequency of exposure in a source population. And what we measure is the incidence, the number of new cases over time in the exposed and the non-exposed group. And then we are able to compare those incidences, that is new condition, new health condition. We're able to compare and give measures. And this is what we are then able to say the risk of being this, and in relationship to a disease. The measures of occurrence are usually, we measure things like illness, injury, or death in exposed individual. The advantages of a cohort study is that it clearly evaluates the relationship between exposure and disease. We are clear that you are exposed before the disease happened. So you can talk about the causal relationship. The participants are free of disease at time of exposure. And you define that status. You show that is happening, that status. And then there's a clear temporal trend. The exposure happened before the outcome. The advantage of cohort studies is that they can explore rare exposures. Many of these occur in the workplace. And unfortunately, the people who develop the disease are few, so it's hard to get a meaningful evaluation. So the cohort study begins before the exposure. So you need to be able to identify people who didn't have the disease before the exposure. And the other advantage of the cohort study, it can explore a range of health issues following the exposure. This is the famous NACE study. If you Google it, you find that many studies have been done on that cohort. And the cohort study has the advantage of minimizing selection bias, which is a big problem with case control studies. The disadvantage is that they are time consuming, especially if you have to follow people for a long time. Often you actually need a case control study to test a hypothesis that has been derived from the case control. So then you go on to do the cohort study. Because there's a long time between the exposure and the disease outcome, they are prone to errors that are brought about by people who drop out of the study. You know, people who you can't find and be able to ascertain what the outcome were. Yeah. we have a retrospective cohort. This is when you, as the researcher, you come, everything has happened. Exposure happened, outcome happened, but for a good reason, there was a documentation, so you have data in front of you that you can use to do that as a retrospective cohort study. You can do a prospective one where you're enrolling people as they are exposed to whatever agent you are evaluating, okay? And everything happens in the future. And then you have a bidirectional study where some of the participants already have been exposed and gotten the disease, and you're just adding the numbers. I've seen this kind of bidirectional studies being used more, particularly the postgraduate students doing surgery, where accruing your cohort quickly enough within your training program is difficult, okay? There are other studies, famous studies that have looked at the same. For example, the US Air Force study on Agent Orange, this dioxin study on its impact on the health of Vietnam veterans, people who had been soldiers on the ground in Vietnam and were exposed to this Agent Orange. Okay, now let's look at some examples of cohort studies, and then some examples of randomized trial studies. I hope this is giving you ideas of how you then go select the study design for your study. And actually, once you select the study design, then the issues you need to fill in for all the other sections of your study, they are standard. You find checklists on the internet, and it's all go. So this is what I studied from back in 1991, a prospective cohort study. Actually, this was a very important study, and it was looking at postnatal transmission of human immune deficiency virus type 1 from mother to child. And the study was done in Kigali, Rwanda, by Professor Philippe van der Peer. And you can see it was actually published in a top medical journal, the New England Journal of Medicine. Now, can I have one of you read this out? Now, can I have a volunteer? And please listen, because there will be some
Kindly
questions.
raise your hand so that I can allow you to speak. Whoever wants to volunteer, kindly. I can give you speaking rights. Any
Let's have a
volunteers,
volunteer.
kindly?
Are people too tired to volunteer? The Brenda, just choose one person.
Okay, I see Terry's hand is up. Let me just give her rights.
Yeah, in fact, you have two participants. The other one will read the other case. This
Okay.
one. Mm.
Right.
So
There you go.
Evening.
back then, although transmission of human immunodeficiency virus type 1, HIV-1, from mother to infant has been well documented during pregnancy and delivery, little was known about the possible transmission of HIV-1 during the postnatal period. Methods: a prospective cohort study in Kigali, Rwanda, of 212 mother-infant pairs who were seronegative for HIV-1 at delivery. All infants were breastfed. The subjects were followed at 3-month intervals with Western blot assays for antibody testing of mononuclear cells by a double polymerase chain reaction, in brackets PCR, using 3 cells. Each mother who seroconverted was matched with 3 seronegative control women.
Continue.
Results. Results. After a mean follow-up of 16.6 months, 16 of the 212 mothers became seropositive for HIV-1. Of the 16 infants, 9 became seropositive. 1 infant was excluded from the analysis because of a positive test by PCR on the blood sample obtained at birth. Postnatal
Continue.
seroconversion to postnatal seroconversion to HIV-1 occurred in 4 of the 5 infants born to the mothers who seroconverted during the first 3 months postpartum, and in 4 infants of the 10 mothers who seroconverted between month 4 and month 21. In all cases, the infant seroconverted during the same 3-month period as the mother. The main risk factor for maternal seroconversion was being single. Conclusions. HIV-1 infection can be transmitted from mothers to infants during the postnatal period. Colostrum and breast milk may be efficient routes for the transmission of HIV-1 from recently infected mothers to their infants.
Thank you. As we saw from the beginning here, study was published in 1991. In 1987 and also in 92, World Health Organization said that mother-child transmission of HIV through breastfeeding was not a big problem. That it was a bigger problem, the bigger problem of children dying from lack of breastfeeding. And so at that time, the guideline was that women should breastfeed regardless of their HIV infection status. This was when we did not have any antiretroviral drugs. The antiretroviral drug story came in about 1996 in the Americas and Europe. So you can see this was a question, this was an important question. Do babies, is there mother-child transmission of HIV through breastfeeding in the postnatal period? And so this a research group set out to try and answer that question. And we've read the abstract. And so I ask you, what was the inclusion criteria into the study? And people can post your comment there on the chat box. Please post. What was the inclusion criteria? And what was the exclusion criteria? You have posted something here. Yeah. There was exclusion of seropositive babies at birth. The child should be seronegative after birth inclusion criteria. I see the other one. When they set out to go and do the study, who did they include? What? Okay. You're correct that the babies needed to be seronegative at birth. And the inclusion in the study was seronegative women at the time they were at the time of delivery. Okay. So in designing your proposals, you need to be clear what is your inclusion and what is your exclusion criteria, and what are the outcomes of interest that you want to see. What is the outcome of interest in this study? Please post. So the outcome of interest. I'm waiting. What was the outcome of interest? Let me ask different. What was the outcome of it? Yes, I see one post. Yeah, yes, post-natal transmission of HIV. So the inclusion was a seronegative mother-infant for HIV at delivery. Okay. So then, who formed the exposure group? Who are the exposed group and who are the not exposed group? So the outcome was to assess seroconversion of seronegative babies exposed to seropositive mothers through breastfeeding. So the exposure was a seropositive mother, and the controls were I'm making you think very late in the night. So we recruited and seronegative women, and all babies are breastfed. We make sure that this is making sure that if there's breast milk, breast milk transmission, you want to give the opportunity to measure it. If babies who are not breastfed, they would not have met the criteria of being in this study. They would not be, because they would not be exposed. So when you are writing your inclusion criteria, pregnant, HIV, seronegative women, and who plan to breastfeed their babies. Out of these were women who seroconverted in the post-natal period, and 196 who did not. And none of these babies were infected. Then among the women who tested seropositive, 9 infants became seroconverted, and 7 infants not infected. And I think 1 infant was excluded because their blood sample was positive, all right? It's the same slide next there with those 5 questions. In clearly, the exposure is breastfeeding milk from an HIV-infected mother. And the ascertainment outcome is periodic measurement. There was periodic measurement of infant to check for HIV infection status. So you needed to follow the child, retain them in care, and measure repeatedly. And that's why we had results of the 4 out of 5 who seroconverted in the first 3 months, and then the others who seroconverted in the period between 3 months and 21 months, of which they are being followed up. So all these things, you need to think through them and put them down as part of your methodology or your study methodology, and part of thinking through how you will analyze the data. Now, the 196 were seronegative. None of the babies were infected. So the control group, and they show really there's clearly a causal relationship. Your mother was negative before. Those who stayed negative, their babies didn't get infected. Your mother got seroconverted, and some of the babies actually seroconverted. And those who seroconverted early, so the baby the infant is young, the immune system is not well developed, they had a higher seroconversion rate than those exposed later when the baby maybe the immune system has matured a bit more and they're able to, or they're having a lesser dose of the infecting product. In their first few months, maybe it's getting breast milk only. Later, there's other food, so maybe the dose of virus that they receive is lesser. All right, and we'll come back to this criteria of when you see an association, you're asking yourself, is it causal? Is there a relationship? So we've illustrated how the case definition of outcome of interest is important, and we define levels of severity where applicable. And then you need to define the key independent variables of interest, which are predictors and risk factors for the outcome that you're interested in, okay? And when you're writing your proposal, you can give the reference, first reference where these case definitions have come from. Now, generally speaking, when we do these observational studies, so I've talked of case series, we've talked about the environmental studies, we've talked about case control studies, and then now these cohort studies. They have challenges in the interpretation of the data. And these challenges may be related to how you selected the participants, the role of bias, selection bias, information bias. If you're asking people about things that happened long ago, you may not have good data. If you go to the medical records of where the data are used for, say, for example, employment records, they may be incomplete. You may find that a person who maybe there's crossover. For example, a person who's been working on a factory floor and got sick, the company may decide not to sack them, but bring them to work in the office. When you go and extract data retrospectively, they used to work on the factory floor, and although right now they're on the record of people in the office, they were an exposed individual. But because you don't know that, you may place them in the category that is and it's as you may label them unexposed, and so you have misclassification, which leads to diminishing the estimates of the risk when you do your computation. And again, these are topics that need to be tackled on one-on-one. And randomized clinical trials may help to overcome many of these problems, and we'll talk a little bit more about them. Now, the case control study also is a form of observation study, and it's useful when you're looking at a disease that is rare. Sorry. All these are good for a rare exposure. Case controls are good for a rare disease. And usually this, of course, will be retrospective. We are recruiting somebody when they already have the disease, and we are comparing them to somebody who doesn't have the disease. It is less expensive, it is less time, and you're able to accrue enough numbers for a patient with rare disease and a long latency. For example, I just heard of somebody who's doing a study for their PhD. They're looking at the women with the fibroids, and their question is, do hair products, use of hair products, the palming, I guess palming and all that, are they a risk factor for fibroids? Now, if we start off with the recruit people who are having their hair done and they're palming or whatever, and then wait until they develop problems to decide whether the exposure was was a risk factor. It would be actually an exercise in futility because first of all, it is a long time. It's expensive to follow people up. There's potential for loss, a lot and lots of loss to follow up. But if you go and find individuals who already have fibroids, say for example, I think the study they're planning to look at women who have an ultrasound and ultrasound diagnosis of fibroids, and then interview them to find out about their exposure to those hair products. They'll have to look for controls, and the controls should be women who don't have fibroids, who come from the same environment as the women who have the fibroids, so as to control for other factors that may have played into the disease. And herein is the weakness of our case control study, that it's very difficult to get good controls to be able to answer the question. Okay. Now, randomized trials are the gold standard for evaluating treatments. Of randomization is, of course, the blinding. There are the issues of ethics. First of all, blinding, and then ethics. We only randomize if you have what we call equipoise. Okay? That you don't really know whether treatment A is better than treatment B. And when we analyze, we do an intention to treat analysis. In this instance, some of the people who are in that, we know that when you randomize somebody, they don't always necessarily use what you give them, but we retain them in that arm of the study. Part of your work as a researcher when you're doing these randomized trials is to, every time you meet a patient, to encourage them to adhere to the product that you're having them do, or the activity that you're having them do. It can be challenging, okay? Of course, it takes time and expense, and we can only test the interventions that we can control, or exposures that we can control. I've talked about the dropouts, and then of course, in the middle of the study, the treatment may change. So it's no longer ethical to continue with a particular plan of action. And I'll give you an example of that. I have an example of that for you. And then, of course, because the population that goes into a randomized trial is highly selected, there may be limited ability to generalize the results to the bigger population. All right. Basic design of a randomized trial is as shown here. You have eligible subjects, and then you randomly assign them to intervention and control. And one of the first steps when you come to study doing your data analysis is to check whether your randomization was successful. And successful randomization is where, at baseline, the intervention group and the control arm look the same. If they are not, you have a problem, okay? We do RCTs when we need to know causal relationship, usually introduction of a new treatment or strategy, and I've already said that there must be clinical equipoise, and there must be an open ethical window. Once we know that a new treatment works and works better than the old one, there's no room for a randomization, and in fact, at that time, we need to progress everybody to the better treatment. Now, the randomized trial cannot proceed when there is doubt regarding the ethics. Remember, patients will be exposed to either test or control treatment, and sometimes the control treatment is a placebo, and the person is being enrolled into the study because they have an illness. And the question is, this new drug, does it work? Now, the new drug may be working, but it also has harmful effects. So hence the need to do the research. In fact, your ethics committees can be very helpful in the critiques they give of your randomized trials are very helpful. When can we do a randomized trial is when the exposure is modifiable. You as the investigator can modify the exposure. There's genuine uncertainty regarding which intervention is superior, and the outcomes are relatively common and occur fairly soon. So you're able to make a decision in a reasonably short time. Now, let's give an example of sometimes you have exposures like smoking. It's potentially modifiable. So there were studies, that randomized pregnant women smokers to cigarette cessation program versus standard of care. So you can't randomize to smoking because there's some harm, but they want to see whether we use a program for cessation of smoking, whether there'll be a good outcome. And the outcome was birth weight. But at the end of 8 months gestation, they found that 57% of the women in intervention smoked, and 80% women in control smoked. And so it was like that in the control group, okay? So remember the women who were recruited were women who were smokers. They were pregnant and they were smokers. And you are randomizing them to cigarette cessation versus standard of care, which is, the antenatal care without a specific focus on modifying their behavior. All right? Important. So we now know don't smoke during pregnancy. Now, I think we can skip this because we've talked about it. Now, one of the advantages of randomization is that it distributes confounding variables and produce comparable groups. That's what I'm talking about. And a good randomization is that your intervention and control arm look the same. Confounding is also referred to as a selection bias. The more important thing is that randomization deals with not with all confounders, those that you as an investigator know, but more importantly, those confounders that the investigator is unaware of. Now, about a study to show that there are other methods of dealing with confounding depending on the data of the type of confounder. And we use this, for example, in cohort studies or control studies, matching, multivariate modeling. Remember there was I think we give an example of some the stratification, for example, in the example we've seen of HIV, analyzing those babies who were infected in the first 3 months versus after. That's a form of stratification, and which helped us to show that some level of effect modification, that the younger infant is more vulnerable than the older infant. The confounding is that an association exists where none exists, or it masks a true association. So the confounder may make the exposure more likely, or independently, it modifies the outcome. This is a common problem in observational studies, and it can also occur in poorly designed randomized studies. So we need to be careful as we design our studies so that we don't introduce confounding. Now, a precondition for confounding is that the exposure, which is A, related to B, is related causally to B. But X will be a confounder if it meets the following criteria. Is a risk factor for B, and X is associated with, it's a risk factor for B, and X is related, is associated with A. But it's not the result of A. So they are just as they are associated. Often, for example, low socioeconomic status, poverty, so hunger is a risk factor for, say, low birth weight. And populations that are low socioeconomic status may be less aware of the risks of smoking. So they may be more likely to have a person with low socioeconomic status may have a higher likelihood of being a smoker during pregnancy. So X is not the cause of the smoking, but it's associated. But X is known to affect B, the causal relationship. Now, these concepts are not easy, and one keeps having to come back and think through what were they saying. So don't feel that it's becoming too difficult to understand. So the hormone replacement therapy was, and I'll show you that study shortly. The use did not reduce the risk of coronary heart disease. So I think whether hormone replacement therapy in postmenopausal women could reduce coronary heart disease. Now, women were recruited in the study if they were healthy. So this healthy woman effect. So if you're healthy, then you are less likely to have coronary heart disease, even if you are using hormone replacement therapy. So then there was and you will see the data. Like I said, you'll see it's an interesting thing. Particularly in this hormone replacement therapy, it actually it overstated the protective effect of estrogens and progesterone on women, both men and both women, and actually it was causing harm. When they finally did randomized trial, those relationships fell out. The randomization distributes confounding variable even in the two groups. Then it removes the crucial preconditioning for confounding. In this case, the healthy woman effect will no longer be associated with hormone replacement use. Okay. Right. And so this is this was the study, and it was the Women's Health Initiative, a classic study, very important study, which looked at this hormone replacement therapy. It was the compared women on estrogen alone, women who had a prior hysterectomy, and were put on estrogen alone as a hormone replacement therapy, versus those who had a placebo. And you can see, that, for example, the age screening who are 3.6 years. If you look at, say, race, known 1.4, 1.4, duration of hormone use greater than 10 years is 20.3 and 27.5. So really, they had very good randomization. And usually when you do your study, you will need to actually do a table like this and actually test each variable and confirm that they are not significant. There's not significant difference. this is just another of the same, slightly different study in the same group. Okay. Let's see. Now, let's talk about local randomized trial. On the breast milk study, which was randomized trial of breastfeeding, which we did actually here in Nairobi. We knew that HIV is transmitted in utero at delivery and breastfeeding, but the contribution of breastfeeding to mother-to-child HIV transmissions separate from pregnancy was controversial. We didn't know what was the magnitude, and we also didn't know the importance of the duration and intensity of breastfeeding on transmission. It was unclear. And so it would make it difficult to give recommendations. Yeah? The question that we faced was, why should it be necessary to conduct analysis to quantify the magnitude of HIV breast milk transmission? The issues were that breastfeeding in its own right is helpful. It's helpful to babies. It prevents other infections. It reduces mortality. We now know that breastfeeding even promotes baby's IQ. But at the same time, we knew that an observational study would be a challenge because not every mother would be able to afford the breast milk. And also what we found as we did our analysis is that women who are sicker, so the mother who is more likely to transmit, the mother who has higher viral load, low CD4 count, was more likely to self-select into formula feeding, so that the results then become confounded, like we heard about. And so this is what this slide shows. There were other social risk factors for HIV, differences in risk of HIV transmission. I've talked about socioeconomic status, sexual history and behavior, HIV disease state, and infant factors. And these CS factors could work as confounders in this relationship. So we set out to determine the frequency of breast milk HIV transmission, to compare the mortality rates and HIV-free survival in breastfed and formula-fed infants. We actually did a randomized trial between those years of 1992 and 1996, and we recruited 425 HIV seropositive participants. All these were ART-naive women. There was no ARVs then, and we ended up with 401 mother-infant pairs being analyzed. Those were babies survived the live delivery and were able to follow the babies forward. And this was the design of that study, published in year 2000. And this is what we found at that time. So ARV-naive women randomly assigned. This was transmission rate. Those who are breastfeeding, and this was in those who are formula feeding. We then did the HIV-free survival, and it followed the same pattern. But you can see here, you remember I told you that you need to compare your intervention and your two groups. Here it was breastfeeding and formula feeders. I need to show that your randomization worked. And this was very important for this study, because this was the first and probably the only randomized trial in an ARV-naive population. And you can see we looked at very many variables, not economic factors, the obstetric factors, the mother's lab and viral load factors, but we also looked at other factors that may contribute to transmission. And here were the issues of sexually transmitted infections, the whole work. And so we were very happy. We succeeded in having a good randomization. And the basis of this, we estimated the rate of breast milk transmission to be 16.2%, and 44% of HIV infection in the breastfeeding arm was attributable to breastfeeding. And most of that breast milk transmission occurred early, the first 6 months actually. Now, the 2-year mortality rates in both arms were similar. And it took us a long time to try and understand this, scratch our head about it. And but the HIV-free survival at 2 years was lower in the breastfeeding arm at 58% versus 70%. There are subsequent studies that then used the same parameters for measuring child outcome. And once you had ARVs in the picture, so we're doing less transmission, the HIV-free survival has always been better in those who are breastfed. So this was the only scenario where had what's outcome. Now let's change gear and look at that post-menopausal hormone therapy study, a series of studies that we were talking about. Now, in the past, hormone therapy was often prescribed to postmenopausal women. And at that time, they thought that they were preventing coronary heart disease and they were preventing osteoporosis. Let me assure you that really postmenopausal women really suffer, particularly osteoporosis is a big issue. So when they get fractures or just a minor fall. Now, the observational studies had showed a protective effect of estrogen on the heart and bone. And this practice continued for over 50 years without randomized clinical trials, I guess because it is women's health, and women's health wasn't a priority. You can see this is from the US between 1982 and 1992. The increase in the proportion of women using hormone replacement therapy. All right. In fact, this discussion was just on. We were talking on breastfeeding and HIV around 1991, and I remember when we were in class doing our MPH class, there was discussion about this use of hormone replacement therapy. There are more than 30 observation studies that showed estrogen prevents heart disease in postmenopausal women. The cohort studies and case control studies showed 30 to 50% reduction in coronary heart disease among hormone replacement therapy users. Women using estrogen without or without progestin had more favorable levels of low-density lipoproteins and high-density lipoprotein cholesterol, and those assigned to the placebo. So this was a good thing, isn't it? And beneficial effects of vascular reactivity were shown in clinical trials or in the laboratory. Other benefits were possibly the reduced risk of osteoporosis among found among women who are on hormone replacement therapy. There was, however, increased risk of endometrial hyperplasia, and this risk was reduced by adding progestin. Now, the observation of breast cancer risk in women showed mixed results. So the question was, will all postmenopausal women benefit from hormone replacement therapy? Does hormone replacement therapy really reduce the risk of coronary heart disease? And does hormone replacement therapy increase the risk of breast cancer? The only way this question could be answered at this point was to do a randomized trial, okay? So the Women's Health Initiative was a series of trials set up in 1993 to 98. A large number of women were enrolled. Women, 161,000 women aged 50 to 79 years. And they addressed several questions, including the effect of low-fat diet, calcium, vitamin D, and hormone replacement therapy in 2 trials. There was a large double-blind placebo-controlled study of hormone replacement therapy of 27,000 women of mean age 63 years. So you can imagine this was really big stuff. Women were randomized to a set of 2 hormone therapy trials. One was unopposed estrogen versus placebo in women who had had a hysterectomy, and combined estrogen progestin therapy versus placebo in women who had a uterus. The hypothesis was that hormone replacement therapy would result in reduced coronary heart disease, and a hormone replacement therapy will increase breast cancer. Around about 1991, 92, 1 in every 10 American women was dying of breast cancer. So it was a very important study at that point. Study, and this is the set of that particular study. So women screened, this was reported no hysterectomy, randomized estrogen progestin or placebo. So these were, the estrogen was a conjugated equine estrogen. Right now we use their newer safer estrogen preparations. And then this is women who had had a hysterectomy, again randomized to combine estrogen hormone therapy versus placebo. What do you think the results were? Anybody aware of what the results were? Because this is a really famous study. Have you learned hormone replacement therapy currently? This is what happened. Was that 5 years instead of 5 years instead of 8 years, because there was increased benefit. The health risks exceeded the health benefits. There was increase in coronary heart disease, increase in risk of stroke, venous and thromboembolism in the HRT arm, and increased risk of breast cancer in the HRT arm. And today, actually, we no longer give postmenopausal women this combined estrogen hormone replacement therapy. And these are sort of the summary of those findings. Very important. Of course, the hormone replacement therapy was associated with better bone health and reduced colon cancer. But this other thing was so bad that most women do not touch it. Most women will not hormone replacement therapy. This really it illustrates the importance of and the value of randomized clinical trials. So the people are left with the question of why did the observational studies fail to detect the harms associated with hormone replacement therapy? And it goes back to the issues we discussed about when the observational studies are prone to selection bias. I think in the medical circles there was it was terrible because for 50 years we'd been giving medication that was harming women, and many women had been harmed and died because of that hormone replacement therapy. The doctors gave it thinking really it was good stuff. So for us going forward, new interventions you need these randomized trials. And even in our own country, we need to invest in those so that really we treat patients correctly. This is the other is to illustrate in a similar way using the mother-child transmission. Again, in the early 90s, this was the transmission rate. The pediatric HIV was actually a rapidly fatal disease. We needed an intervention quickly. The animal models indicate that COVID may prevent or cause of maternal acquired HIV infection. So this study was the prevention of other infant HIV transmission. It's a multi-center randomized trial in the US and France. And what they saw, this is what they randomized 427 pregnant women, 39 to 230 placebo, and what follow-up month HIV transmission rate, and you can see that was a big difference. 8.3% versus 25.5% in the placebo arm. It was actually a 67.5% reduction, and p-values you see this. And this was at the first DSMB. You remember we discussed how DSMBs are important in telling us whether our intervention is working and whether a continuation of that intervention is actually harmful to the group that is in the placebo. And this is an example about that, okay? And so the study was stopped. It was stopped early. They went back and checked some of the parameters to see whether the groups were similar at baseline, to confirm that there was not a bias, in the results. And so they found them were similar, and so the intervention just works. Now, for you to be able to do this kind of analysis, then you should have collected your data well. And this slide just emphasizes the differences between quantitative and qualitative data, and the differences where you're testing a hypothesis with your quantitative data and understanding the why with your qualitative data. Your study design, of them you have to, to think very clearly. Usually in quantitative, you have a very formal and systematic collection of data. And in a qualitative, it's a lot of it is observation related, but this has moved also. We have moved to being actually a little bit more structured. So we are structured in who we interview. We are structured in terms of having an interview too, even when we do these qualitative studies. Studies usually have a structured and even structured responses. For some of the things that are categorical data, it's important to collect continuous data like age, CD4 counts, total white cell counts, to actually collect the absolute count and do your categorization when you're doing your data analysis. And then, of course, the analysis, you need to develop right statistical techniques. And usually we talk about descriptive data and then comparing the exposed and unexposed to find out factors associated with the fact you have been looking at. While in qualitative studies you are identifying the themes that emerge from the data. Yeah, in quantitative studies, we're going to do tests for significance. We don't do that with the qualitative data. To do your studies, you need to do a sample size calculation, and the sample size calculation is based on what your study design is. And usually you would go and look at the literature and find out what was the frequency of the factor you're looking at in different studies, and use that within in the equation of calculating sample size so that you get an adequate sample size. Doing a study that doesn't have an adequate sample size is unethical, because you put people through this whole exercise, but whatever data you get, you cannot use. So the sample size calculation is important. Consult as a statistician. Let them help you with that calculation. Make sure you write your study procedures very carefully, okay? How you selected participants, how the enrollment went, the consenting process, the flow, the follow up, or even another, you're looking at medical records, how you identify those records, how you start, what records, how did you, was it random, did you get them out of a set of records for a condition that you're doing an audit? Did you do a random selection, or did you collect consecutive, did you collect them consecutively, okay? You need to talk about how you abstract those records and you de-identify the data. You will describe your study too. This can be the questionnaire or the case record form. You will describe your clinical procedures where they are relevant and lab procedures where relevant. And please read published studies and see how people describe these methods, the level of detail that is required. You will then also deal with ethical issues. I won't go into detail because we talked about the 3 principles: autonomy, beneficence, and justice. You need to address those in whatever study. And from the issues of risk, I think we covered that quite extensively in our last session. Then you need to talk about data management. How are you collecting the data? Are you using paper records? Are you using an electronic form? How are you protecting that data for confidentiality? And how are you cleaning your data? Excel is very readily accessible. You can use it for collecting data and even analysis, but it is not a strong data collection tool because your data is not protected. Whatever you key in, you can change it. If you key in a wrong thing, it's very hard to identify whether it was wrong or not. So there are other data platforms like Access that are used for collecting data. The beauty is that today the different data collection tools or software communicates very easily with the data analytic tools. So you can collect your data in Access, for example. You can analyze it using SPSS. You can use it, analyze with R. You can even use OpenEpi for your analysis. The first step in your data analysis is always to describe who was my study population. After I went and recruited, did all that stuff, and finished all my data collection, who did I collect the data from? And you describe them well: socio-demographic characteristics, clinical characteristics, or other characteristics that you're interested and you have predefined in your study. You then now go on to compare those who are either exposed versus those who are not exposed, or your cases versus your controls, and then you're able to compute the risk factors, and you need to pay attention to what you compute. When you do cross-sectional surveys or case control studies, you do odds ratios. When you have a cohort study or a randomized trial, we use incidence data and relative risks to compute your measures of disease or measures of disease outcome and measures of disease association. And then, of course, the other things, comparing the medians from one group to the other, to see whether they are similar. And I showed you the tables for that. Now, as you finish, you also put in your references. So all the things you've done everywhere, those ideas you put there, why you said the question was good, the background literature review you should have been referencing, and then you reference it here. Please practice using the Vancouver style of referencing, where the first reference you use is number 1, and then all the others after that, 2, 3, 4, to whatever number. Try and restrict at this stage. Try and restrict your number of references to about 20 at this point when you're writing a proposal. Be selective about the references that you use, and you can't use everything, but that means you need to read your papers carefully. And I'll show you a slide how you select. Now, whatever results you have when you finally do your study, you must remember to subject it to this question. Remember that what you see as a relationship may be truly causal, but it may be due to confounding. And I've given you examples, hopefully convincing examples. So you ask these questions. Is there a temporal relationship? We talk about cohort studies, you know, somebody started off unexposed, they were exposed. And then had the outcome. So that there's clarity. But in a cross-sectional survey, you don't know. You're measuring exposure and outcome at the same time. You then look at the strength of association. And in looking at the strength, you want to see if there are those response. So what more did they get more? Like the example of that early randomized trial breast milk transmission of HIV, one of the analysis we did was we've collected and analyzed it to find out whether you could recover it, whether there was detectable. Those who all their milk samples always had virus. Then, and mothers who they were intermittent shedding, and mothers who never had HIV virus in their breast milk or the infection, the HIV transmission was higher. So how long was I lost?
Maybe like a minute or two, but you're back.
I'm not sure when we lost it now. Anyway, let's just continue. So
the slides are not up yet. I think you need to reshare. Prof, we can see the slides, but we can't hear you. You're muted.
saying that this slide shows the evidence that when you're doing your literature review, finding the meta-analysis, the systematic reviews or controlled, randomized controlled trials, this is the higher, stronger evidence. And would start here. And it's only when you don't have any on the topic, you then start sliding down to these your cohort studies. And like I said, stick to about 20, no more. And the more recent published, unless a topic has not been dealt with previously. So I want to stop here I said that the test of whether we understand how to write a proposal is like the test of meat. It's in the eating of that meat, okay? It's like a nyama choma. It looks good, it looks like it's doable, but the test of it is actually just getting down to it and actually doing starting to write your proposal. Don't start with the title, start with a question. And when you're starting with a question, go to get a bit of literature review and study justification, and your literature review, you keep going back to improve it. Then think about your methods, what is the most appropriate study design, eh? And once you have hashed out that, then you now start building around the details of your research study. And keep working with whoever is your mentor, whoever who is supervising you. I actually, when my trial was a very important study, I came out of a discussion in class. The CDC was saying mothers should not breastfeed. WHO was saying was breastfeeding. My question was, really, HIV infection is big in Africa? Is the physiology of African women is not different from others? So is it true really? Is what being said true? These were two completely opposite recommendations. And so, first of all, wrote an essay around it. One of my teachers challenged me, said, well, we could do a randomized trial. And I said, yeah, sure, we would do that. And that became now the proposal that I worked on to develop the proposal. And really the rest is history. A lot of things have been learned from that particular study, many publications of it. People working on the samples that we collected and looking at different things. Very important, you work with your mentors, work with your peers, work with your colleagues. This is how great ideas are developed, all right? This is how you make progress as researchers. Linda, I think we need to stop. Siku, I see we have lost some of the participants. If there are bits of this proposal writing that they'll need gone over in more detail, I'm open to coming back and doing that. This is
Sure.
Yeah, and I hope you understand why I said right at the beginning, it can't be done in one lecture, in one webinar.
Yes, I agree with you. And I think it's also, as you said, in proposal development, the researchers need to work closely with the supervisor, because some of these things will make more sense when you're doing them practically. Yeah, so thank you so much for the presentation. If there are any questions, I'm not seeing any in the Q&A. Feel free to raise your hand or chat. For the next 1 minute, we see if there are some that we can address. However, I think it has covered quite a bit.
I appreciate the introduction that you are a group that was ready to answer questions on the chat board and interact. And I see, Sharon, you've even posted a thanks for the presentation. So this is good. This is a beginning, eh? And I'm sure I look forward to seeing you become successful researchers. Yeah.
Yeah. I think also these slides would be useful even beyond this program, because even I, as a postgraduate student, have found the content quite useful for my research. So it's to encourage the participants to keep the notes, and the knowledge will come in handy for a very long time. All right, there seems to be no questions, so we will end the webinar here. Thank you so much, Prof. Ndwati, for facilitating the presentations on proposal development, and we hope to see you again soon.
Yes, and I hope that maybe you consider having groups work on, as opposed to one individual proposal, one person per proposal, maybe a bit of teamwork, especially at this stage when you're still new. I think teamwork helps to encourage each other and build some skills and not, yeah.
Okay, sure. We'll pass the feedback now to the coordinator and the members as they are developing the proposals to consider working in teams for topics. I think all the participants are supposed to do their individual work, but I guess that's something maybe that can be discussed with the coordinator as well.
Yeah.
Yeah.
Oh.
So thank you so much, and the attendees, thank you for your time. See you again next time. Have a good night.
Okay, thank you. Bye-bye.